Welcome back. So, in the previous session, we were talking about study limitations and the quality of studies, as well as bias that could happen in research. If you have not watched that session, I encourage you to go back and watch it, or you might proceed along. And if there anything that's not clear to you, you may want to go back and watch not just the previous session, but the entire series. Today, we're going to continue talking about bias, but we're going to specifically spend some time discussing my good friend, maybe not a good friend of researchers, but a very, very interesting concept called confounding. So we're going to talk about, we're going to spend some time talking about confounding, and then we're going to talk about what bias is not. In the first session, we talked about what bias is, what types of biases there are. And then in this session, we're going to talk about what bias is not. And we're also going to talk about how bias is reported in meta-analysis. So to my friend confounding. Now, I'll tell you a story. Some time ago, some researchers decided to examine the association between coffee drinking and the incidence of bladder cancer. This was before coffee drinking became a fashionable thing to do. The results found that people who drank, I believe it was 2 coffees or more per day, had a higher likelihood of getting bladder cancer. Now, here comes along some more detailed researchers, and they say you did not take into consideration the fact that people who tend to drink a lot of coffee also tend to smoke a lot. And that was how that study was saved. Um, in this case, coffee drinking was confounded by its relationship with smoking, or to say that in a better way, the relationship between coffee drinking and bladder cancer was confounded between the relationship between coffee drinking and smoking cigarettes. And so this brings us to the definition of confounding. Your exposure, and so let's build the case. Your exposure leads to your outcomes. But what if there's something that is both related to the exposure but can cause the outcome? So when you see the exposure, you see this thing called the confounder. And in that relationship, it really is the confounder causing the outcome. That describes the situation of confounding. Now, let's go into more technical explanations of confounding. And it is this: a confounder is typically associated, or has to be, not typically, has to be associated with the exposure. In the story I just told you, coffee has to be associated with smoking. The confounder has to be associated with the outcome. So smoking, as we now know, causes bladder cancer. And so when you have this thing, smoking, that's related to the exposure, which is coffee, and the outcome, bladder cancer, you say smoking is a confounder of the relationship between coffee drinking and bladder cancer. But there is a third way, and it is that you cannot have the confounder along the causal pathway. So, for example, if people, if because people drank coffee, they become smokers, and then they get bladder cancer. Smoking is in the causal pathway, and so smoking cannot be a confounder in that situation. But that is not the case. Can anybody tell me what smoking would be called in that situation? Maybe I'll tell you at the end of the session. Okay, so let's look at an example. And while you're at home, you can do these calculations to confirm this with this example data tables that has been provided for you. But let's talk about this conceptually. So in this situation, we're trying to understand whether diabetes is a confounder in the relationship between smoking and the outcome of acute MI. In this case, it's an acute myocardial infarction, which you could call, or which is also called a heart attack. And so we know that smoking is associated with heart disease and heart attacks. And we also know that people who have diabetes, the high proportion of them, or higher proportion of them, a high proportion of them tend to be smokers. People who are not smokers are less likely to have diabetes. So in this case, diabetes is both associated with the exposure and with the outcome. And so in this case, we would say that diabetes is a confounder of the relationship. And like I said, you can practice this at home and you can do this mathematically. You can see the proportion of people who smoke who have diabetes and people who smoke who have MI. And you'd be able to see that the people who have diabetes, a higher proportion of them, or rather, people among people who smoke, there's a higher proportion of them would have diabetes than people who do not smoke. And that could be the reason why you're seeing this improved or increased, not improved, relationship between smoking and acute MI than would happen if you had controlled for diabetes. Okay, so let's talk about what confounding does to validity. So, what is validity? Validity is how correct your results are. And so, you've probably heard people say as association is not causation. And we can have an entire philosophical discussion about that. But now, when people say association is not causation, in very strict terms, they could be referring to the fact that there is some confounding that there is some confounding that you have not controlled for. When you control for all type of possible confounding, then an association is causation. But let's move from there. What confounding does, or one of the things it does, is it introduces bias into our point estimates. So we talked before that your point estimates are the effect measures that you calculate: hazard ratio, a risk ratio, a rate ratio, an odds ratio. And what bias does is it introduces bias. Remember, we talked about bias being systematic error that leads you to a wrong conclusion or incorrect answer. And so bias impacts on your validity, and confounding creates bias. So if you have confounding, it leads to bias. It leads to low or poor validity of your results. So confounding. So so the different ways of to measure validity. What's the point estimate, the HR? What's the OR? But also, what is the validity of a p-value? Are we certain that this is the actual p-value or the confidence interval? And the confidence intervals are really, really important because they give you a measure of uncertainty. They let you know how tight our conclusion on the point estimates that we made are. And when you have confounding, just like with the example in the previous slide, you could have an increase, incorrectly increase, or you could have an incorrect decrease, lowering either to the null or away from the null. And that's what confounding can do. And of course, we just talked about the confidence interval. Your confidence interval may be too wide. Your confidence interval may be incorrectly too small. Your confidence interval may actually shift and not capture and not be in the center what we expect. Basically, the conclusions you can make about your point estimate would be wrong when your confidence intervals shift or are too wide or are too narrow. Um, when people talk about confidence confounding, I beg your pardon, they it's sometimes confused with effect modification. And even though both of them are similar, they are not the same thing. And so we say that confounding is undesirable. Why? Because we want valid results. But effect modification is different from confounding, and sometimes you actually want to see what the effect modification is. And a very quick example of effect modification is, suppose, and this is not suppose, this is what studies have found, that when patients are given what we call baby aspirin, low dose aspirin, the effects of low dose aspirin on preventing mortality or or heart disease is different in men than in women. It works in both men and women, but to a different effect. Maybe it could work better in men compared to women, and that is effect modification. So in this case, sex has modified the effect of this intervention on this outcome. And that is not confounding. That is at the level of the stratification. You're going to see differential effects. And if there are differential effects between subgroups in a population, you want to take that into consideration. Whereas if there's confounding, you do not want to have that in your results. Okay, so let's move to the next slide, and then we'll talk about how confounding can be managed in your research. And so you want the first thing is you want to do your matching. So suppose you were looking at smoking and heart disease or acute myocardial infarction. When you look at and you find that there are patients, you of course you're going to be comparing people who smoke with people who don't smoke, and look at the incidence or the occurrence or the prevalence of acute myocardial infarction. But if you found that for every you could to do your matching, you would say that for every patient who is a smoker that has diabetes, we are going to analyze our data, or we're going to recruit a patient, or we're going to capture a patient into our data set who does not smoke but also has diabetes. So that's matching. And so you control effectively, neutralize the impact of diabetes on your results. You could also restrict. So for example, you could say in this study, I want to capture the relationship between smoking and acute myocardial infarction in people without diabetes who smoke. So you in from the get-go, you're going to say, if you have diabetes, we're not going to recruit you into this study. So that's called restriction. And restriction should not be confused with representation. In restriction, you say, because we want to look at this effect for this subgroup or this population, people without the people who do not meet the criteria strictly for this population would not be included in the study. And of course, randomization, which we talked about earlier, but let's talk about it again. When you pull from a population randomly and you randomize effectively, what you have is that the group A on the left, if you randomize them to left and right, group A on the left is equal and exchangeable with group A on the right. And so any effect you see, any differential effect you see between group A on the left and group B on the right will be as a result of your intervention. But you would notice that I've talked about these three things in your study planning or when you're recruiting. What if you find that there is a potential confounder after you've done your study? During your analysis, you can control for confounding using statistical adjustment, which we call multivariable regression analysis. And the multivariable regression analysis just means that instead of only the independent variable in your model with the dependent variable, you have those items of those potential confounders included in the model. So you have multiple variables in your regression model. There are other advanced techniques, propensity score matching, inverse probability weighting, and so on. And those are a little beyond the scope, but feel free to pick up a textbook or go online and read about them. Okay, now let's move to what bias is not. So remember that this is a continuation from the first session discussing bias. And we know that bias is, you know what? I'll tell you what bias is not. So remember we had said that bias is when your results are wrong as a result of systematic error. The first thing bias is not is we are not talking about bias when we find, unfortunately, that someone forged the data. That is not what we're talking about. Being fraudulent is totally frowned upon and unacceptable. But when we're talking about the statistical concept of bias, that is not considered. So that's the first thing. That's the bonus for today, what bias is not. Let's talk about other things that bias is not. So bias is not imprecision. And so what is precision? And so precision could be imprecision or precision. You could understand it as how wide your confidence interval is. But to have a wide confidence interval, of course, your bias, we said earlier, your bias could lead to problems with your confidence interval. But having a wide confidence interval, meaning having an imprecise result, is not the same thing as being biased. Bias leads to the wrong point estimates of your study. That is your wrong ORHRRR. Okay, so and the reason we want to make this difference is because bias is occurs due to systematic error, whereas your imprecision leads to randomness in your analysis. So it happens because how do we say this without getting philosophical? It happens because life and your data collection and everything, just due to randomness alone, some error gets into error gets you have random error, and it's not the systematic, like something goes wrong, which is your systematic error that cascades on and on. And so your precision also depends on your sample size. So you see that even if you get the right estimate, if your sample size is really, really small, your confidence interval may be really, really wide. So you are not wrong. Your results are not biased. It's just that your results are imprecise because of your sample size. And in some cases, not in some cases, but very, very much so, you may not be able to get you may not be able to be precise because the occurrence of what you're looking for is rare. And this is very similar to sample size. If your sample size is small with a rare outcome, of course, the number of the events that happen, for example, myocardial infarction, will be low, and then it will increase your sample. It would increase your confidence interval, and you would have imprecise results. Okay, so bias is not external validity, and this is a good one. So external validity is the extent to which you can say the results we have here. For example, if we run a test of a new drug in Ghana, the extent to which you would say, well, we expect to have the same results in Zambia or Zimbabwe or Morocco, that is external validity. And and bias is not external validity. You may be unable to generalize. External validity is also called generalization. You may be unable to generalize your results. For example, let's see, if you do a study in patients who are anemic, who have severe anemia, you may not be able to generalize that result to healthy patients or healthy people, or people who are in the army, who are super healthy and even maybe healthier than the general population. But that does not mean the results of that study in patients who are anemic are biased. It is just a different population, and you may not be able to generalize or to have what we call external validation. Okay, so let's talk very quickly about reporting, and just to say what we've said. It's that you have bias. And bias is not, for example, when people forge results. Bias is not when you have imprecise results. Bias is not when you are unable to generalize to a larger population. Bias is your systematic error. Something goes wrong in when you're recruiting, when you're collecting data, and it leads to a deviation of wrongness in your point estimate, in your HR, in your OR, or in your RR. Now, so let's talk about reporting of bias in your studies. And there are two tools that we're going to talk about very briefly. They're the Cochrane risk of bias and the Cochrane risk of bias in non-randomized studies of interventions. These are not the most ambitious of names. It's the Cochrane risk of bias tool that assesses risk of bias. Okay, so as you can see, the Cochrane risk of bias is used, or is best suited for randomized trials, whereas the Robbins one is used mostly for observational studies, your cohort studies. And let's talk about what they focus on. And you can see that these two are really, really the same. Uh, it's only that they're very similar, maybe not the same, but they're very similar. But your Cochrane risk of bias, the one at the top, helps you check your biases from randomization, and we can talk about that in beyond the scope of this class. But because of the assumption that you may not have, it's very unlikely that you have confounding when you randomize because of what we've explained earlier. But your Robbins one, which is the one below, you can capture and report on confounding, on participant selection, on the classification of interventions, whereas your ROB2 looks at deviations from assigned interventions. In the earlier session, we talked about what can happen when there are protocol deviations. We also have an older scale, the Jadad score, and a scale that's currently used but not as widely used as the Cochrane tools, the Newcastle or Tower scale. And I encourage you to go into the Cochrane website and also do a Google search for these other scales and take a look at materials that have been published for how to use them. Okay, and I think this might be our last slide. But how do you capture bias? And let's start with the figure on the right. When you have a set of different studies, and as a researcher, you look through and you say, well, I think this study has selection bias. You can either create an Excel or use some kind of tool that would say, of our 10 studies, for example, one of them has selection bias. And so you can see here, or maybe instead of saying one has selection bias, say one of them has unclear risk of bias, and then you would have green for 90%, and the one here would just be unclear risk. But here you can see there's an issue with blinding, and you see less than 25% did not have an issue with blinding, but about 75% had high risk of blinding. And just looking at this visual, you can determine what the quality of the studies you've examined. And here, maybe there's a little subjectiveness, but I would say apart from the blinding of participants, these these studies and maybe the clinician experience, these studies look of reasonably high quality, given that we don't expect everything to be perfect. On the left here, what we're doing is you're looking at the individual studies instead of summaries, and you are grading them. And if you were here, I would ask you which of them is more intuitive. How do you make a decision about the overall quality of your study by looking at the one on the left, which is a summary of all studies, versus the one on your right, I beg your pardon, and the one on your left, which is a analysis, evaluation of individual studies. And if you do not like these visual representations, well, let's talk about you can put your studies on paper, and then you can get to a point where you look through the studies and say, well, overall, I think this study has a moderate risk. Of course, you don't just do that on the surface and say this is moderate, this is low. You go through the different aspects here that are lined up here, and you assign and say this is low, this is high, this is unclear, and then you make an assumption at the end. It's very similar to what you do, especially here on the right, but you do it without using the visuals. At this point, I would ask you, what are your key takeaways regarding confounding? What are your key takeaways regarding what confounding is and what confounding is not? And your key takeaways on what bias is and what bias is not. And I encourage you again, like I said, take a look at the different tools used to present the risk of bias in studies and let us know what you think. Thank you very much.